Okay, so what is actually a static perimeter? You can see here, this is my Humphrey visual fields. This is the static perimetry. So whenever we do a static perimetry, the stimulus of a known size, okay, so we have, I would tell you what is the size of stimulus. There can be stimulus 1, 2, 3, 4, 5, various sizes can be there, but whenever you are doing a perimetry, it is only the one size which you basically select for the patient. Okay, so the known size is basically presented and the intensity can be varied. Okay, so sometimes the intensity can be a lighter one, then there can be a brighter one, but remember, the brightness of the bowl is always the same. Okay, so background has the known brightness. Very important here is that central or peripheral visual field, whatever you are going to test, you can test in these type of visual fields with different strategies. You can have a 24-2, 30-2, and after doing this visual field, you can compare the results of this visual field with the normative database. So that's why they are also called automated perimetries. Okay, so remember, why automated? Because the computer itself has programs which can tell you whether the results that you are seeing is coming under the preview of a normal person or it is coming in a preview of a abnormal sensitivity for the patient. Now we come to the perimeter. So this is the bowl. So this is a aspherical bowl, and the distance of, let's say this is your bowl and this is where the chin is put. So this distance, they sometimes ask what is this distance. So this distance is around 30 centimeter. Now it has a matte finish which is basically done so that there would be less reflections from the room. But remember, always do this in a dark room. These are the dark room procedures, and these stimuli look equally bright in all your directions. Okay, and so whether you see it here or here, so all the stimuli look equally bright in all directions. So that is what is important for a perimeter. So remember, a Humphrey visual field have three important components which can tell whether the patient is doing the visual field correctly or not. First thing is video fixation monitor. Okay, so as you can see, we would put a video where the visual fields are being done. You can basically monitor how the patient is doing it. There we have a head tracking and a vertex monitoring. So what head tracking does is, if patient opens the mouth or moves the head, it would tell you. And then there is a vertex monitoring. If there is basically patient has to put his chin over the rest, and if this patient moves the head more than 7 millimeter, the machine would alert the examiner that the patient is not doing it correctly. Okay, so these are two important points which basically help the examiner to know whether the patient is doing the visual fields correctly or not. So the next thing, we go with the various strategies. Now we have various strategies when we do a visual fields. Our question so many times is which strategy which we have to basically choose whenever we see a patient. So first of all, what the strategy means. So first of all, you must have seen 30-2, 24-2, 10-2 or 5-2, what it actually means. So we come to all these one by one. So first of all is central 30-2, which is so commonly done. So it means that we basically do a visual field of central 30 degree where we basically test 76 points which are 6 degree apart. Similarly, we have 24-2 where the central 24 degrees tested. Here we test 54 points. So as we test lesser points, it is a bit faster, and it is also the 2 points are 6 degree apart. Similarly, we have 10-2 where the central 10 degree is tested, but remember, the number of points that are tested in central 10-2 is more than what we do in 24-2, so it is sometimes even longer than the 24-2. It basically tests the 68 points. And then we have less commonly used, which is 5-2, where we just test the 16 points which are 2 degree apart. Now sometimes the question occurs, what is this 24-2, what the 2 actually means? So similarly, you have to remember that whenever we do it in horizontal and vertical meridian, where we basically point the various stimulus. So if the stimulus is on the horizontal and the vertical axis, so this means 1. Okay, so if they say 24-1, then the stimulus are basically put on the vertical and the horizontal axis. And then what 2 means? 2 means that our stimulus are basically 3 degree apart from the horizontal and vertical meridian. So 2 points are 6 degree apart, and the points which are nearest to the horizontal and vertical meridian, they are 3 degree apart from the horizontal and vertical meridian. This is the basic meaning of dash 1 and dash 2. These are sometimes asked in your exams or in your viva. Now we have central 24-2 and 30-2. As I told you, 24-2 is the pattern which we commonly use in the glaucoma examination, where we test 54 points which is 6 degree apart. But one point here also you have to remember is that whenever we do a 24-2 in the nasal quadrant, okay, so remember, in the nasal quadrant we basically do it up to 30 degree. Okay, so why we do it? Because you must be knowing that a very early glaucomatous defect may be a nasal step. So to basically identify or diagnose a nasal step, so central 24-2 nasally extends to 30-2. This is an important viva question and an MCQ. Similarly, we have a central 32-2. Now what this 32-2 means, that here whenever we basically test the blind spot, we basically do put 2 stimulus which are basically at the blind spot to measure it. So this is called 32-2. Now there is another visual field pattern which is one of my favorite, because it is done very quickly in my OPD fields, because this is called HVF 24-C. Now why I call it 24-C? The C means here the central. So C here goes for central. So what a regular 24-2 means is, we do a test 24 degree, nasally we do a basically 30 degree, and we usually take 54 points which are 6 degree apart. What we do in a 24-2C is that, like a regular 24-2 pattern, we also test, please remember, we also test central 10 points, okay, that basically tells us if there is any pathology near your fixation, that is basically near your macula, which might be missed on a plain 24-2. So here, if you can see in these lines, I would underline these 2 points, that they basically test any visual field defect which is around the macula initially, that can be missed by 24-2. So if you do not have 24-2, then what would 24-2C, then what would you do is, you would do a 24-2 plus you would do a 10-2. So here you can do both in one, and it is, remember, in faster mode only. What is theta fast, what is theta faster, I will tell you in further slides. But basically what it does is, it basically has the times which is almost equal or even lesser than a normal theta 24-2, and it basically gives a better structural functional correlation as compared to 24-2, which are some important points regarding that HVF 24-2C. Now it is available in most of your Humphrey visual fields.